It's a pleasure to be here today to speak with you all. I first want to start by saying that I acknowledge the Indigenous communities whose lands we are on, and that my work to promote anti-Black racism and the elimination of anti-Black racism is not done um, at the expense of Indigenous communities or Indigenous people. So I'm going to be talking about Black communities, HIV care, and the moment that we're in that I've termed racial reckoning. And I hope people are recognizing that we are actually in a civil rights moment in Canada. And I don't want that to be lost on those of us who work in HIV as well. Um, as as has been highlighted, we have been dealing with three pandemics simultaneously: um, HIV, anti-Black racism, and the COVID pandemic. But it's important to understand the pandemic of anti-Black racism and the impact that it has been having on those of us who are living with HIV from the Black community and those of us who are providing care and support. Just in case we lose connectivity in the Zoom world we're in, I'm going to tell you what the end of my presentation will be and what you need to be walking out of here with. And it's the same thing I usually say in every presentation, but I'm hoping that it will stick at some point. Organizations who hold themselves accountable to Black communities immerse themselves in understanding systemic anti-Black racism and commit themselves to our survival and well-being will be the most successful in their work with and for Black communities. It's important to understand that working with Black communities is about making a commitment to the community and making a commitment to the people. It's about understanding the systemic racism that we are experiencing that is unique to Black people, and that your work is about our survival and well-being. And sometimes we don't understand what that actually means and what is involved. As Jason highlighted, we saw justice yesterday, but I always say there's no justice for those who are dead. What we saw was accountability. And so making a commitment to Black community is also being accountable to the community and the people who identify as Black. I took a look at the CTN website. I was looking at all your amazing strategic priorities and your statements. I love this statement. This is yours. To make big change, you need big impact. So I never ask people to do anything that they haven't already committed to. And so I will be talking about making big change and how to make big impact. But when you read the strategic priorities of any organization, all of the front facing things that you say you will do, it's important to be able to read those through the lens of Blackness, in my point of view. So when I'm reading your strategic plans, I'm reading them as a Black woman. And I'm just going to run you through a few, because oftentimes we put up these statements and hope that communities can immerse themselves in our priorities as opposed to the priorities actually speaking to the community that we want to serve. So if we just take a look at network structure, governance, and management, just to show you this very simple exercise that I would ask all of you to go and do in your own organizations or the spaces that you occupy. To sustain a national infrastructure that enables Black Canadian researchers to conduct innovative HIV research in collaboration with the Black community. Now, that's how I read the statement as it's written. I've added who I'm focused on, which is, does your strategic priorities speak to Black community? I'll give you another one. Excellence of the team. To continue as a high performance, service oriented, and accountable organization that supports Black researchers in delivering and translating high quality science with a measurable impact on the health of Black Canadians and beyond. What your strategic priorities have to do is speak to Black people in a very specific way. And that is just an exercise that I would ask anyone to engage in. It's part of the work of actually now providing care and support for Black communities and showing your commitment as well. It's also important for us to understand a few things that we're no longer going to research, debate, question, answer to. I think we're at a time in, I think, our maturity where we should understand these things well so that we're actually providing service to Black communities appropriately. The first non debatable point that I want you to walk away with is understanding that we must recognize that Black communities function within a society which is anti Black in very specific and deliberate ways. Difficult for us to talk about in Canada, but we need to. We have to understand that the foundation of this country is based on two things: the containment and extermination of Indigenous people, the containment, the expulsion of Black people when they're no longer required as enslaved Africans, and then extermination when we can't do that. Black people arrived in Canada with the British and French. We are the first racialized population to be in this country. The foundations of racism and discrimination are housed in the discrimination that Indigenous people experienced and simultaneously Black people experiencing as well. So we've had the longest exposure to racism in this country. Second non debatable thing to understand in the context of doing your work with Black people, and I'm telling you these things because you need to understand our experience in order to provide services effectively. Direct and indirect exposure to racism and social exclusion are linked to Black community disproportionality in all societal systems. Every system that we have to engage in to function in the world, Black people are disproportionately experiencing negative outcomes. School systems, criminal justice system, child welfare system, healthcare system, we can go on and on. You need to understand that in terms of understanding the people that you're working with as Black people are not just experiencing discrimination in the healthcare system, but how is your work going to impact alleviating discrimination in all societal systems that we're navigating? The third non debatable thing: there were clear indications that Black communities experience broad health disparities due to anti Black racism they experience. I think we understand this, but we don't design our programs to acknowledge this, to acknowledge that Black people are the only race of people who can watch a murder of someone from their own community from beginning to end, televised daily, and the impact that that has on one's mental health and mental well being, and solely due to anti Black racism. So it's to understand that the work that you do has to be rooted in understanding the trauma and a trauma aware process for people who are experiencing societal, institutional, individual, and structural racism all the time at the same time. To do the work well, we need to function within a framework. And the framework that I like to promote is one of anti oppression. The goal of an anti oppression framework is to disrupt any form of oppression. I'm talking about anti Black racism, overturn it within the system that you function in or the organization, and then reconstruct that system so that the oppression can't happen again. And in the space that we're occupying today, we're talking about oppressive values in research, definitions that label communities as problematic or difficult, policies which exclude equity deserving communities, or developing policies without communities present, institutions that fail to protect us as Black people in particular, and oppressive researcher subject relationships that we often fail to call out. I think we are very good at the disruption phase. What we haven't seen in the HIV world is the overturning of the anti Black racism that's being experienced. It's still cycling through. So disruption happens, but we don't overturn. And we have not gotten to any place of reconstruction where we've reconstructed our spaces and practices to completely eliminate anti Black racism. It's also important, and I have a short time with you, so I'm just going to highlight things that I think are extremely important for us to understand providing HIV care and conducting research with Black communities is understanding spatial and temporal placement, where we're placed and how we've been placed. This Canadian census is really important for one to study and to study the Black community in particular. 1991 is highlighted on this um, census data because it's the year when the Black community doubles. We become a critical mass in 1991. Between 1981 and 1991, this is when the epidemic, the AIDS epidemic, is really taking off. And in that time period, the Black community is doubling. We also see during that period all of the systems responding to the growth of the Black community. So we see criminal justice doubling down, right? We see the education system doubling down, child welfare doubling down as Black community is growing. We have to really sit down and think about what was happening within the HIV sector during that period for Black people. Now, interesting enough, during that time, this is a picture of me graduating. I I was very optimistic about life in that moment, and very idealistic. And upon graduating, I was offered an opportunity to begin a program for continental African people living with HIV. Very brand new organization, and I was going to be developing the counseling and support services for that program. I was the only employee, and I don't know what made one think that one employee could do this for the entire population of African people, but I believed I could. What I did not understand and know, and unfortunately came to learn, was that no one was coming to help us as Black people, that we didn't have family physicians who would see our clients, that we would not be getting the funding to do the work that we needed to do, that researchers were not coming to figure out what was going on with us. And we had to develop these programs on our own. Now, luckily for me in that organization, which is now known as Africans in Partnership Against AIDS, one day I got a knock on the door from a woman who is still in my life over 30 years now, Wangari Thoreau, who said, "We can do this. We are going to do this." The one thing that she said to me is that when you find a snake in your house, you do not spend time trying to figure out how it got there. You get it out. Um, at this stage, we now have to figure out how it got in. We have to figure out how it got in, because we're trying to change the direction of how HIV is impacting Black communities. And so we now have to go back and figure out how that snake got in. What are the structural and systemic issues that we need to address in this sector to ensure that we turn the negative and poor outcomes that Black people are experiencing in our system? I really appreciated the last presenter's description of well being and understanding the social determinants of well being. What we need to understand is that for us as Black people, the social determinants of health and well being are as they are. And racism used to be one of them, or it still is. I've taken it out because I want you to understand that anti-Black racism actually amplifies each one of the social determinants of health. Housing, we know, affordable, stable housing obviously will provide one with stable health outcomes. But anti-Black racism impacting housing means A, it's going to determine where I live. It's going to determine whether someone will rent to me. It will determine whether I'll get a loan to buy a house. Will a real estate agent even sell me a home? All of those things are impacted by anti-Black racism. So anti-Black racism impacts each one of those social determinants of health, which constrains our choices as Black people. And that's what increases our HIV risk. It's also important to understand when working with Black communities that you need to add to the social determinants of health things that are very specific for us. Trust, whether I trust or I have deep mistrust of the healthcare system or researchers is going to determine how well I am in terms of being able to access services and whether my choices will be constrained. HIV stigma and what does that look like for Black communities is also something to understand. So I'm asking you to expand your definitions of social determinants of health. I'm also saying that in order to provide proper HIV care, you can't do it without addressing the impact of anti-Black racism on all the social determinants of health. And that also becomes part of your work, not just providing HIV services. I know many of you experience this, where there are other pressing matters outside of being positive, but we need to incorporate this into our frameworks and how we develop services and what we're researching and how we're doing the research. Something as simple as where are HIV services located in relationship to Black people? Very important because we're struggling to get to the limited services. We still don't have a woman's HIV clinic in the province. Women's Health and Women's Hands, which I spent almost 20, well, over 20 years located in, is downtown, a very small little blue area at the bottom of the map in the center. These are all the spaces where our PHAs were traveling from to come for services at Women's Health and Women's Hands because it's the only site that was providing very specific community-based uh, healthcare services for Black women living with HIV. So people traveling from Grimsby, traveling from Guelph, on a regular basis for care. We have to question that, right? It is a clear indication of lack of services for this population and lack of priority. It's also important to understand where we show up or when we show up for HIV care in particular, and how do we offset that. When for this is data from Women's Health and Women's Hands Community Health Center. When we look at the people who use our services the most, the top 5% of service users, who's coming the most, you can see the breakdown here for one thing for a community health center of our size and nature. The average age of our highest users is 32. It's very young. That is not uncommon if you think about Black community. And if you saw the statistic in the temporal spatial slide I had up, 60% of our population is under the age of 30. Usually your highest users are your seniors, but not in the case of working with Black communities. The major diagnosis, and it has looked like this for 15 years, at least when I look at this data, HIV is always one of the major diagnoses at a rate of 15%. Diabetes, mental health, so all the chronic illnesses, but more importantly, the comorbidities are also extremely high with this population, 10%. So HIV and diabetes, HIV and mental health, and sometimes all three. We also have to understand, if we're doing work in anti-Black racism and understanding the moment that we're in, how Black people are criminalized and what is the pattern, what has been the pattern, what always has been the pattern is that when we have a disparate experience with a health condition, the criminal justice system is called in to respond. So if we think about HIV and HIV criminalization and who is criminalized for non-disclosure, Black people are overrepresented in those statistics, specifically Black men in particular, 21%, when we only make up 8% of the population, for example, in Toronto. 62% of all news articles that talked about criminalization were referencing Black people as well. We see this even today with COVID in terms of what was sent first in our first wave of COVID. Police orders increased, cutting down of basketball nets, but not hockey nets, for example, in the suburbs. which neighborhoods were patrolled. And then we just saw it again with the increasing of policing authority during COVID, as opposed to improving access to vaccinations, access to services, access to PPE for Black people who have the highest rates of COVID in the city. 9% of the population, but we make up 21% of all COVID cases. We can't move away from trust. Um, I've not conducted a study where we looked at Black people and healthcare, and trust is not the predominant factor in accessing services, even when I'm not studying trust. And I think maybe I now need to study trust and mistrust clearly, but it always shows up in one of our first studies at Women's Health and Women's Hands, where we looked at racism and the impact that it had on young Black women accessing healthcare. Over 50% experienced racism by their healthcare provider. 21% stopped going for health services as teenagers because of that racism that they had experienced. The trust had been broken. In the Every Woman Matters study, 65% of the HIV positive women said that racism was the biggest barrier for them accessing primary health care, and that the experience of racism and being HIV positive created such a level of distrust that it hampered whether they continued going for services or not. In the Sisters, Mothers, Aunties, Daughters research study, we specifically were looking at how to prepare a community for an HIV vaccination when one was ready. And at that time, 81% of the Black women surveyed said they would not take an HIV vaccine if it was available. And 77% believed that their service provider would include them in research without their permission. And we see the issue of mistrust showing up now in vaccine hesitancy with Black communities, but I would say there's no hesitancy. There's just deep mistrust, legitimate mistrust based on racism that people have experienced at the hands of medical professionals and researchers. In our Black Women in Health Equity Data Survey, 45% of our clients arrived for healthcare service when the chronic illness was already in place, and HIV was one of those chronic illnesses that was already there when someone came for their first visit for community health care. And speaking to the delay in coming for service and how that impacts and increases our prevalence rates in HIV. The last point, or the last issue that I want you to think about, is how we ignore and have been trained and learned to ignore disparity experienced by Black people. We at Women's Health and Women's Hands were seeing such high rates of HIV with our clients, and no other clinic was seeing Black women with HIV at the rate that we were seeing. And when asking for assistance and asking people to explain to us what's happening, getting nowhere. So we took a look at the public health database, which they were willing to provide us this information. In the time period that we were concerned about, 842 people tested positive for HIV, and the rates were going down in the province, not explaining why it was increasing so dramatically in our space. When we looked at gender, disaggregated the data by gender, we could see what we all know, the difference between male and female, and it justifies where resources go, how resources are rolled out, and what we focus on in terms of the difference between male diagnosis and female diagnosis. When we looked at the data based on race, all of a sudden things start to look different. For Black men and Black women, what we see is a different split. It's almost 50-50, 56% male, 44% female. When we asked to disaggregate the data based on intersecting gender and race, this is where I get my answer to what we were seeing visually. In every region of the province, Black women had the highest rates of new HIV infections. We were located in Toronto Central, where the Black population makes up 8.8% of the city, but 70% of all new HIV infections uh, were attributed to Black women. And you see the pattern across the province. For those numbers to get so high, we all have to see that as service providers. And what I'm asking people to do is to stop ignoring Black disparity. I shouldn't have to dig in the data to understand it. It should be readily available to us, and alarms should be alerted. Communities should be notified of the experience that they're having, especially us as researchers and service providers. But we are accustomed to ignoring Black disparity. I also say that we should use our power to also promote the collection of race-based data across our healthcare system. We are lucky enough to be able to do that with HIV data, but not across the entire healthcare sector. We know how important it is to collect this data from the vantage point that we have. So it needs to roll out across every area that we're working in healthcare. It's important to, as I wrap up, to think about what your role is. What is your role to play in what I call the research ecosystem? Right? Whose voices and perspectives are prioritized in the space that you occupy? Is there a clear understanding about the history of anti-Black racism in research and the long-standing impact in terms of trust and mistrust? Are we thinking critically about how race is used in our research protocols and how race is used when making decisions? Is there intentional representation of Black people in all of your decision-making processes, considering where we sit in the HIV epidemic, what our experience has been, how we've often been left out, and if we're doing anti-Black racism work, we have to intentionally insert Black people in all decision-making processes. And what is the role of funders in addressing anti-Black racism? In order for us to actually eliminate and address anti-Black racism in our HIV world, each one of these components of our ecosystem has to do its part. It can't be one and some and not the other. All components have to be functioning in sync with this concept of ending anti-Black racism in our space. What is your obligation? And I'm speaking directly to CTN. We have to participate in rebuilding trust with Black communities, trust in the research process, trust in the healthcare system. We have to eradicate the racial bias that exists in service delivery and research. We're still seeing research that is looking at us as subjects and not working with us as Black people, as whole Black people in communities. And we have to increase the representation of Black people as researchers, as research participants, and as beneficiaries of research. I want us to move away from just adding Black people to research that we conceptualize without them, that we are having very deliberate conversations and engagement with Black communities to develop research processes that are very specific for us and specific to upholding your end of the deal, which is a commitment to Black people and their survival and well-being. When we're thinking about what ethical research looks like and what does that mean for Black communities, it's addressing the historical mistrust that has to be just a core component of your research, understanding the impact of ongoing anti-Black racism trauma. To understand before we're even talking about HIV, we are engaged in a level of trauma and will be entering into your space, engaging in that trauma. And trauma awareness is extremely important in the design and how we conduct our research with Black communities. Ensuring diversity of research teams and engaging in open dialogue with Black communities to address what the community needs and priorities are, even beyond research, even beyond HIV. What are the priorities for the community and how are you addressing all of those determinants of well-being if you are really going to live a commitment to this community. I also want you to think about the potential of research to support communities and to be accountable to communities. We have to not just focus on the deficits, but also what is our potential in doing this well and doing this right and being leaders. And I'm hoping CTN can also think about that. When we think about the common rule of ethics, which is respect the individual, beneficence, justice, we understand that. But it leads us to focus on the individual and not community. And we have to now start thinking about community. So how do we do no harm to Black communities? How do we show respect and accountability to Black communities? What does a detailed community engagement plan look like in our research, and making that a requirement, making partnerships a requirement, not just, can you send us a letter so that we can apply for this funding, right? But what is the engagement that is going to happen? We have to think about developing new principles with Black communities. It's important to address the political relevance, especially in this time period, the political relevance of the research for Black communities. We're in a very political time, and how is our work going to support Black people during a moment of racial reckoning? We have to work with Black communities to understand and identify the risks and benefits to the community, right? How our research is going to, how you represent people is how they will be treated. How you represent a community is how it will be treated. So we want to think about identifying those risks and benefits. Dissemination, we do a lot of research that does not reach Black community. It doesn't reach Black community on the ground. So can we really rethink our dissemination strategies and plans? What does data accessibility mean for the community? And ownership of that data when research is conducted with us and for us. And my final dream is to have a national panel of experts in Black health research that will advise CTN and other research bodies on how to conduct effective research with Black communities. I want to thank you all uh, for your time and your energy. That was just a lot of information downloaded in a very short space of time. And I do understand the impact of COVID on each and every one of you. So thank you so much for allowing me to speak to you today.
Wow, thank you so much, Notisha. That was a excellent presentation and has given myself, I'm sure everyone on this call and the CTN to think about. So we do have about 10 to 15 minutes for questions, and everyone feel free to ask questions of Notisha as well of Pooja and Kate. So we're going to open it up. You can put your questions in the chat or unmute your mic and ask our speakers. I guess while we're waiting for um, our attendees to ask questions, I guess the obvious question I would have, Notisha, is what do you think that the CTN should do as an organization as a next step to be moving from that disruption phase to the overturning phase? So I thought that that was such an important thing for us to understand. What should we be doing as next steps? I know you mentioned a lot of them in your talk, but specifically as an organization, what would you recommend we do to address anti-Black racism and many of the items you spoke about?
Yeah, as I thought about it, and it was a little scary to think 30 years have passed, but it's like we're stuck on this spinning wheel where we're talking about it. We have always been talking about racism, um, but nothing has moved forward because we're still saying the same thing. When I looked at the investigators, uh, about 5% of your investigators are Black. I mean, we can start in terms of representation. And it's not just representation, go find more Black researchers, but what is the mentorship? What is the mentorship? And I see you have postdocs. I understand the postdoc process. Um, but an exercise I would ask everyone to do is literally think about if you closed your eyes and you stayed in your identity, but everyone else was Black when you opened your eyes. What would it take for that to be a reality and a possibility? Literally. Or what would it take for you to guarantee that the next person who replaces you in one of these boxes is a Black person? It's to think, well, first of all, I'm asking you to think about something we've never experienced, which is a world without anti Black racism. So I've never experienced that. You've never experienced that. Our parents haven't experienced that. So we have to be very idealistic here, but we have to think about how we are going to increase the engagement of Black people in CTN. And the first easy space to start in is to increase that representation and increase the mentorship opportunities that CTN can provide. But I also believe in the power that CTN has. So that ecosystem I talked about, what are all the things that CTN is going to do to influence each one of those spaces to address anti Black racism? And where's your anti Black racism plan and strategy? So is it 1 year, 2 years, 3 years, whatever you decide, but let's see it. I think um, you know, Black people and HIV is so significant that you can't move forward without a plan that is very specific to anti-Black racism.
Thanks for answering my question. A lot to think about. Do we have, okay, Ritu has a question. So if the snake got into the house due to anti-Black racism, what will be the single concrete step that will kill it? Or I appreciated that anti-Black racism was the snake, but how do we kill the snake?
I see Wangari on the call. Maybe she could tell us what, but I'll never forget that proverb she left with me. But the thing is, our healthcare system is based on, we can go back to, the structure of it, but it's based on something called the Lalonde Report. This is from the 70s. That simply says the communities with the highest need, right? The communities that have the most need should get the most resources. It's very simple. So when you have a community with such high need, particularly in the HIV world, um, the resources should match the need. And we haven't done that as yet. We have not done that as yet. We have not been successful in that area. That the rates of HIV for Black communities are the rates that they are. I didn't go into the detail. I know everyone on the call is very knowledgeable of that, but we haven't matched the resources to enable us to actually do the work that we need to do for a community that is experiencing so much disparity in terms of HIV. That's number one.
Great, I'll open it up if anyone else has any other questions or comments. Thanks, Ritu, for being the first.
I just want to say, Notisha, thank you so much. My name is Neora Pick from the Oak Tree Clinic. I don't think we've ever met in person, but I just want to relate to a few things that you said, especially the trust and the stigma. And so we are a women's clinic and children's clinic. And so although we are located in Vancouver and 40% of our patients are actually at least an hour away from us, we found that even when we try to suggest a clinic like close to where they live, mostly because of trust stigma, and this is more common in the Indigenous and the African communities, and patients, they say that they prefer to travel an hour and a half and then spend the day here where they feel welcome and they feel that all their needs, not only the women's center, but they feel that they're not stigmatized, they're not judged, and they're very respected, and kind of all their needs are met. So they prefer to travel that. And so that was kind of an eye opener for us.
Thank you so much. And I've studied the oak tree model extensively because that's what we want here.
You
Um,
you are welcome to come and visit, as some of you have done in the past.
Absolutely. Once COVID is over, for sure. Absolutely. The I fully understand that, and that's the same response that we get from people who are traveling 2 hours, 3 hours to come without the resources to actually do it. And so that's why addressing trust and stigma then becomes a priority. Um, what ends up happening in our system is that it becomes okay for a woman to travel that far. Understand, well, it's a compliment to you. It's a compliment to how good your services are, as opposed to, no, it's actually a deficiency in the system that is making a woman travel 3 hours, 2 hours to come all the way to us because there's nothing else in between where she can go for service. So I'm trying to move away from that narrative that it's a good thing that you exist, as opposed to, no, it's a bad thing that we have a system where Black, racialized African Caribbean women can't trust providers to support them in their HIV care. So how do I work with those providers to build a better relationship with the community?
So from our perspective, I think the anti-oppression education would be very valuable. And so um, we would be happy to collaborate or bring you. I think that this is very important, and we can start here in BC, at least with some ground rounds and some Women's Health Research Institute rounds, etc., to raise awareness. So basically, my question to you is, how do you raise awareness, bring this to the attention of the policymaker, and basically every healthcare provider should have that, bring it to medical school, and to the clinics. And so raise awareness and education, I think, are really important. And I know Laura Sove is also on the call. She may be busy at the moment, but we were kind of texting in between us about that, because this a third of our patients in the clinic are Black, and so this is very close to our hearts. And thank you again for all your advocacy.
Thank you. I'm going to BC tomorrow, actually.
Really?
Yeah, via Zoom. For
Oh,
your,
okay.
yeah, to talk about race-based data collection. So I will be spiritually with you tomorrow.
In which context?
The university system.
UBC. Cool. I can connect you to the representative of medical school in UBC as well for this as a start. But if you can elaborate on here's Laura Sove as well, on the anti-oppression education, or what your thoughts are on how to increase awareness and bring it to basically, I don't know, maybe BC colleges of physician and NPs and all healthcare provider, basically.
I'm just going to comment that Folasad made an important comment in the chat about their first experience with a service provider with the level of racism and HIV related stigma in terms of dentists not seeing them. So this is something that we see all the time. I have to have a list of dentists that will see my patients living with HIV. So thank you for sharing that experience. And it's really important, and it really highlights what Notisha talked about, which I see, which is this concept of how important trust is, and and people won't come to see you or even get the care if you don't have trust. And we're seeing that now with the COVID vaccine rollout. So thanks for Notisha for highlighting that.